RWJ Lifelight. This is Flightcom. We have an inter-facility transfer request to be from local community hospital going to RWJ University in New Brunswick.
I'm on my walk around. Good.
Alright, trip to extra 100%, no warnings or cautions, no vital systems, normal avionics set. Here we go.
RWJ Lifelight Flightcom, safe on deck.
Are you the primary nurse caring for Miss McGillicuddy?
I am the primary nurse caring for Miss McGillicuddy.
All right. Could we do bedside report?
We certainly can. This is Miss McGillicuddy. She's an 89-year-old female who presented to the local community hospital complaining of cardiac complaints and shortness of breath. She does have a recent history of high acuity catheterization at Robert Wood Johnson with CAD and CABG. The sending physician here and the cardiology at Robert Wood decided that it was in the patient's best interest to transport this patient urgently to Robert Wood Johnson, New Brunswick. She has no known allergy. She has an extensive medical history, which we can go over, and she is COVID negative at this time. Upon arrival, she was hypoxic and tachypnic, and we started her on oxygen on a normal breather. She improved slightly, however, she did decompensate later. So therefore, we did put her on BiPAP. She's on 100% 10/5. Her oxygenation status has not improved that very much since then.
Any allergies to medication?
No allergies to medication.
And when was the last time she ate or drank anything?
She ate last night.
Last night. Excellent. Thank you very much for the report. We need a copy of the chart, 2 on the face sheet, orders for the transport team to include medevac and any imaging you'd like to send.
Wonderful.
Thanks, Ashley.
Thank you.
Basically, as we come into a transferring center from a local community hospital, we have multiple concerns when we're transferring a person on BiPAP to Robert Johnson for advanced cardiac care. We're thinking about not only optimization of our patient, but stabilization. Being on BiPAP in hospital is a tenuous situation where you're sitting there breathing on a machine, feeling a little bit claustrophobic. Being put into an ambulance or a helicopter, there are many transport stressors that come into play. You have vibration, acceleration, deceleration, temperature, the anxiety of the transfer itself, and being switched to a transport ventilator for BiPAP services. So when we look at patients like this, we think about the complications that can arise. Are they able to protect their airway? When did they last eat? Are they prone to aspiration? Is their respiratory status on the edge of respiratory failure? And should we preventively intubate them now in a stable environment of the ICU or ER or cath lab, as opposed in the back of an ambulance or in a helicopter? When we're looking at a head-to-toe assessment and we evaluate, we look at a plan. And our plan is based on our assessment. And we have a couple little algorithms that we go through. For looking at an intubation and ventilation, we have acronyms that we evaluate. First one for ventilation is ROMAN. ROMAN stands for restriction radiation, obesity obstruction, Mallampati, mast seal, mustache, age, and no teeth. This will identify somebody that's going to be hard to ventilate. If you can't ventilate them, you should be cautious with an RSI procedure. The next evaluation tool is LEMONS. LEMONS, you look, get a general impression of their airway. Is it going to be difficult? You evaluate the 3-3-2 rule. You look at Mallampati. You look at obesity obstruction. You look at neck stiffness. And S, one of the most important, is situation and saturation. If their sats are low and you're in an uncomfortable place, it's going to be hard to intubate. Our next one is for supraglottic airway. The acronym is RODS. R, restriction radiation. O is for obesity obstruction. D is for displaced, we cannot insert the supraglottic airway into its appropriate place. And S stands for short neck. In the event we cannot intubate and we cannot put in a supraglottic airway, the backup is surgical crike. Surgical crike, we think of SMART. Surgery, mass, access, radiation, and tumor. When Brian and I are doing our head-to-toe assessment, we think of all these things and then we discuss what areas for this patient are we going to be concerned with. Is it ventilation, intubation? Will we be able to get a supraglottic airway in? Will we be able to do a surgical crike in the event we can't do any of the above? When we're thinking about RSI, there's the 7 Ps. The first P of RSI is the pre-assessment, which we already talked about, but it's also about preparation. What that means is you're going to have your suction out and ready with a large bore suction catheter, making sure it works. You're going to have a BVM attached to the wall, oxygen flowing, and the appropriate size face mask that's functional working. You're also going to have a high flow nasal cannula readily available. You're going to decide what type of device are you going to use, video or direct, physician preference, what size blade you would like. Endotracheal tubes. Have 2 different sizes available. You'll never know what you get until you actually put the blade in. It might be a 7.5, but in this case she's swollen and it's a 7.0. Prep for success. Have a bougie readily available. This is a lifesaver in many different case scenarios. Have the securing device commercial for the endotracheal tube. And make sure your IVs are patent. You've checked the blood sugar. Also, let's make sure that you have either a nasopharyngeal airway or an oropharyngeal airway readily available. Insertion of these is paramount in the event that you cannot intubate her, because then you have an airway available for basic ventilation. The second P is pre-oxygenation. Right now her SAT's 91%. Ideally, we'd like to see 94% or greater. To achieve that, you have a couple options. The first one is a high-flow nasal cannula, at least 15 liters per minute, put on the patient. You can continue the BiPAP at higher flows, or you can use a BVM attached to the wall with the reservoir full and PEEP. After you're optimizing oxygenation, you have to optimize her. What do I mean by that? In the event you give ketamine and you give succinylcholine, there is a high probability that her blood pressure will drop and will be detrimental to her final outcome. So you need to optimize that. Neosynephrine push doses or epi push doses, depending on your preferences and the vital signs you're seeing on your patient. The next P is positioning with protection. Ideally, you want to have the person at about a 30-degree angle, their head looking at the ceiling. Use the sniffing position to ideally put them in place. Intubating people flat that are obese and have kyphotic backs makes the intubation attempt even more difficult. After we've done this, it's time for paralysis and sedation. Sedation first. Choose your medications wisely. We have the options of using either etomidate or ketamine. In the event we feel a little bit soft, we can drop their dose by 1/3. This optimizing them once again and not dropping their blood pressure. Succinylcholine or rock. Once again, user preference. We usually go with rocuronium because that has less adverse effects with certain clinical conditions, and it's 1.5 milligrams per kilo. Once we do intubate the patient, your next P, intubation, and confirmation, we want to make sure the tube's in place. You want to see some condensation in the endotracheal tube. You want to see equal rise and fall of the chest wall. Equal lung sounds, nothing over epigastrum, and the most important is end tidal, quality waveform, and a quality number. No resistance with the BVM, and afterwards, get a chest x-ray and hopefully an ABG within 15 minutes. And finally, the last P is sedation. You want to make sure that they're adequately sedated and or paralyzed for duration. Good afternoon, Mrs. McGillicuddy. How are you? My name is Bob. I'm the flight nurse with Life Flight from RWJ Barnes. This is my exceptional partner, Brian, the flight paramedic. We'll be taking you up to New Brunswick. How are you feeling today? Do you have any pain? Is your breathing okay, or does it seem to getting worse? Open your mouth. Stick your tongue out. Swallow. Very good. Thank you. Take a deep breath for me. Another deep breath. One more. One more. So based on the vital signs and our assessment of this patient, she is an impending respiratory failure. Brian, what would you like to do for our plan of care here right now? I think we should secure her airway and intubate her.
I think so too, Bob. She's just not able to really lay much flatter than what she is right here, and being able to load her in and out of the aircraft that could pose to be detrimental for her and further decomposition. So I think that we need to manage our airway prior to us leaving. This way we don't have to worry about trying to do it in the aircraft, and where we have a more stable environment here and we have resources if we need, and we can check everything prior to leaving.
I 100% agree.
Based on the fact that she's got a soft blood pressure, let's start with some neosynephrine. She's tachycardic at 130.
I agree. I think we should use some Neo, 100 mics IV push slow, and just confirm our dose.
Neosynephrine, 1 milligram and 10 mLs.
100 mics, slow IV push is going on. In 2 minutes, we'll do a quick reassessment of our vital signs, but in that interim, we're going to start optimizing her oxygenation. Let's put her on some high-flow oxygen. Brian, are you good with succinylcholine and ketamine?
Yes.
Good. And ketamine, I think we should go down by 1/3 of a dose. So instead of 1.5 milligrams per kilo, let's go with 1 milligram per kilo.
That sounds good.
And Brian confirming sucks. And here's ketamine. Here's your dose.
Good.
Good. Our medications haven't been confirmed. So at this point, we're quickly reassessing our patient's vital signs. Heart rate now is down to about 112. Blood pressure is 124 over 76. Her saturations are 95%. Respiratory status, she's still a little bit tachypnic in the high 30s. We've optimized our patient with head of beds at 30 degrees. She's in a sniffing position. High flow nasal oxygen has been administered. She's still on BiPAP. Brian is now prepping all of his equipment for intubation. He'll be using a video device, the McGrath. He has his bougie out. We're going to test our ET tube, lubricate the end. Our BVM is ready. Suction is readily available, running at the right side of the bed. Timeout includes we have the right patient, we have the right plan, we have the right medications, all of our equipment is ready, and both of us are in agreement about all of the above. Ketamine's going on, 80 milligrams. A minute has passed. Sux is going on board, 120 milligrams. Our vital signs are stable at this point. Heart rate is 110. She's become sedated and she's becoming paralyzed. So we're assisting ventilations. The pediatric BVM is being utilized so we don't over-distend her lungs. We have a PEEP valve on. It's at 5, and Brian is about ready to intubate.
Okay, full. Visualization of the cords.
There you go. Your cuff is inflated.
1 second.
Auscultating over the belly.
Inflated.
No sounds. You have sounds over the left. Sounds over the right.
Got an end tidal of 48.
48. Then we hit reassess for vital signs.
A repeat just came up now, Bob. It's 118 over 72.
Even better.
And setting at 96% and sinus at 115.
Perfect. At this point, all we have to do is think about our last P, preparation for sedation. We're going to think about what we're going to use. We've used ketamine. It's readily available. She tolerated it well, so we'll probably give her some additional ketamine at 1 milligram per kilo. And we're going to put her on the ventilator.
And we're going to have the nursing staff have the physician put an order in for a stat chest x-ray as well as a stat ABG from respiratory to see how Mrs. McGillicuddy is doing after the intubation.
We have equal lung sounds with the ventilator in place. And our vital signs remain to be stable. Well, thank you very much for watching our presentation. I hope that helps you make some clinical decisions in regards to intubation prior to transport or in the hospital for CAT scanning. We are RWJ Barnabas Life Flight.
Flycom, RWJ Life Flights departed going to RWJ New Brunswick. Flycom, RWJ Life Flight down secure, Robberwood.
RWJ gets down secure.